Hi, I'm Fiona and I'm Quality Improvement Coordinator from the Centre for Safety Innovation, and I'm going to just give you guys a bit of an insight of how we work with our Communicating for Safety at BHS. Okay, so Communicating for Safety, like other elements of care that we give, always our overarching principle is partnering with our consumers. So within version 2 of the national standards, Communicating for Safety now encompasses the correct patient ID and procedure matching, clinical handover, communication of critical information and documentation of information. So it's just purely not about our handover, but it's our communicating and how we do it safely. And underpinning that, we have clinical governance and quality improvement to support each of these elements. So I guess really the key messages of today, we want to involve our patients in their care. We know that effective communication is vital for patient safety. All people receiving care, therapy or services from at BHS must be correctly identified and or matched. We use structured communication tools such as ISBAR, which I'll speak about shortly. And we know that handover must include a transfer of accountability. So if you're not comfortable with the information that you've been received, feel free to ask questions because that patient will be then coming into your care. And we want relevant, accurate, complete and timely information that the patient's care is thoroughly documented. So partnering with consumers, as I mentioned, is our overarching principle with every care that we give. We know that effectively communicating with patients, carers and family during high-risk situations actually improves patient outcomes. Therefore, we really need to actively involve patients in their own care, meet the patient's information needs and really share our decision-making with them. So correct identification and procedure matching. Our expected objectives and outcome in this organisation that all our patients, clients and residents at BHS will be correctly identified and or matched to their intended care, therapy or service at each treatment episode. So we have 3 approved identifiers that we use with all aspects of these care. So when we have our inpatients, the 3 approved identifiers are that we identify the patient's name, both the family name and the given names, the patient's date of birth and the patient's medical record number, which is their UR number. When they present to the ambulatory services such as radiology, our outpatients, the clinics, we also identify the patients using their patient name, their family name and given names again, their date of birth and their home address. For those of you that will be working out in residential services, we identify these residents by the resident's name, so the family name and given name again, and asking the resident if they are able to tell us their name, their date of birth, their medical record number, the UR number again, the resident's photo, and then clarifying with another staff member. Okay, so patient identification is confirmed at admission or registration, whenever we provide care, therapy or services, whenever clinical handover, patient transfer or discharge documentation is generated. And on our SharePoint page, we actually have a suite of vignettes that actually you can view to see how we do this at BHS. So we also use an interventional safety checklist, and these are for patients that are in theatre, radiology, cath lab, ECT, and these must be undertaken prior to any procedure or intervention occurring across BHS. Individual specialist areas will have a clearly documented process for how patient ID procedure matching occurs in their areas, and really it's just an extra safety net to ensure that we're providing the right care to the right patients. The failure to correctly identify our patients and match that information to intended clinical intervention can result in significant clinical harm. And we really encourage any incident involving patients not being correctly identified or mismatching of a procedure or treatment or a near miss to be reported on our riskman system. And again, that's not a blame game, it just allows us to look at the trends and where our gaps and improvements can be made. So if you ever have any discrepancies between patient ID and documentation of an expected procedure, at any stage then the procedure should be stopped completely until that's been resolved and confirmed. So moving on to clinical handover, we know that good handovers do not happen by chance. Good handovers require 4 key principles, and we need preparation by the staff involved. We need good leadership and active participation in the handover process. We need structured communication and understanding of the information that should and shouldn't be included, and we need that clear transfer of accountability between the giver and the receiver. So these are just a couple of definitions on clinical handover. So it is the transfer of professional responsibility and accountability for some or all aspects of a care of a patient, or a group of patients to another person or a professional group on a temporary or permanent basis. So the handover may occur simply when you're taking them to theatre. It may occur on a longer term basis when you're getting a patient from ED to the wards, and it can also occur when the patient are discharged out to the community. Structured clinical handover really just allows us a way to deliver the information. We sort of refer to that as the minimum information content, and enables all participants to know the purpose of the handover and the information that they are required to know and communicate. So once again, engaging patients and carer in the clinical handover process is absolutely paramount. So patients, carers and families should be key participants in the transition communication process. The patient's preferences and choice should be known and respected. And really, patients are the best ones that can give us their insights into their conditions and the circumstances that can affect their ongoing care and needs. It's proven that patient engagement and communication at these transitions of care actually does improve our patient outcomes. It prevents adverse events during their care, and it actually reduces readmissions to hospital after discharge. So I can't emphasise enough involving our consumers. Around the acute wards and the subacute wards, each of our patients have one of these communication boards up at the bedside, and we really should be updating these every shift. The patients love these. We do regular spot audits on these. Sometimes compliance isn't as good as it should be, so I really encourage staff to use these boards and involve the consumers when you're updating those. So moving back onto clinical handover, it is the transition of care when all of a part of a patient's care is transferred between healthcare locations, clinicians or different levels of care within the same location. And again, it really is just to provide a relevant, accurate and current information about the patient's care to the right person, and that action is taken to continually to ensure that our patient care is maintained. So there are multiple situations where we'll be doing handovers during our shift and during the day. So these include our shift to shift, so our change of shift handovers, transferring patients to another ward, transferring patients to another facility. So we'll transfer many of our acute patients out to subacute. When we escalate a patient condition to a doctor, we're actually handing over that information. When we take a patient to theatre, when we take a patient to diagnostics such as radiology, when we make a referral to the multi-D team, we're actually giving a handover to that team. When we do a transfer letter out to another facility, again, another handover. And when our doctors do their discharge letters to the GP, that's also a form of handover. Bedside handover is a really important aspect of care at BHS. We spent a lot of time trying to implement this several years ago, and we really need to make a point to ensure this happens at a minimum of AM to PM shift. Just check your individual areas where we'll be transitioning to all shifts. And the most important aspect is that we're actually involving the patient in the handover. We're not standing at the end of the bed talking about them, we're actually speaking with them. Bedside handover is also a way of showing professionalism. It gives us consistency and structure within BHS. We're actually complying to the standard, communicating for safety. So not doing bedside handover is actually a real risk in relation to our accreditation processes, but also around best patient outcomes. It is a structured communication model. It decreases errors. It ensures patient safety, and it is best practice. And many of you would have undertaken bedside handovers at other organisations or as students. So moving on to a standardised approach with communication. Why do we have this? Well, basically communication is a daily task that we can never escape from. They say it is rarely explicitly taught, but we do have a lot of ISBAR education occurring as undergraduate students, and most staff will know what ISBAR is now, which is really reassuring. We know that if we deliver standardised communication, the referrals to both the giver and the receiver are clear. We know again that ineffective communication can compromise patient care. And as we become busier, complex, higher acuity, effective communication is absolutely paramount. So really need to ensure that our communication is spot on. So again, most of you will be aware of ISBAR, but basically what ISBAR does, it really just does provide a standardised structure for communication. It helps prioritise information for both parties. It decreases the chance for getting relevant, important information, and it helps to decrease assumptions by making the reason for the call obvious at the outset. That's when you're ringing a doctor, for example, to escalate. And really it is best practice, and it helps us to deliver our best handovers. So what is ISBAR? So identifying situation, background, assessment and request. and this is the endorsed communication tool for Ballarat Health Services. So what does that mean? Identification is simply by identifying yourself to the patient and ensuring that you identify the 3 patient identifiers. Always introduce yourself to the patient and the patient's family. The situation is when we talk about the situation at hand. So state the immediate issue or the current situation, and if it's urgent for a review, for example, please say so. Background is when we talk about the patient's past history. You want to have a relevant past history and tell the story being concise. Assessment is what you think is going on at the time. It may be related to some abnormal vital signs. And the request is being clear about what you are requesting, who is responsible for the actions, and setting some clear timeframes. So also on that suite of vignettes I mentioned, there is one on shift-to-shift handover, but I would discourage you guys not to look at that. We're doing some significant work around shift-to-shift handover. We're moving away from sitting behind a closed room for an extended period and moving towards a safety huddle approach to shift-to-shift handover. So watch this space, there'll be some exciting things happening. Going back to ISBAR, when do we use ISBAR? Again, clinical handovers, making and receiving a phone call, delivering verbal information, handover documentation, referrals, presentations on case rounds, or transferring or receiving a patient from another area, unit or department. This is just a little bit of information about making the call. Again, that's just reflective of what we spoke about. So for the nursing staff working in both acute and subacute, we use a BOSSNet nursing handover system. Each of the areas will give you some orientation about how to use that. It's really simple and a very effective handover tool. On that handover sheet, which I'll show you an example of, the key risks for the patients are identified. Things such as if they're a high falls risk, if they've got a pressure injury, if they're on any high risk medications, and if they have a current infectious status. You'll be given a current login and password, and like I said, a very simple IT system to use. So when you commence each shift, this is the handover sheet and that's what it will look like. You can see it's also in ISBAR and it will provide you all that minimum information content that you can safely care for your patients. Also, you'll notice as we are still in a hybrid system, we do use some electronic and some paper-based forms. We do have a suite of handover forms and again, they're all in ISBAR, clearly outlining the care requirements. Again, like our patient ID incidents, we really encourage reporting of any incidents that occur around clinical handover. We know that poor or absent clinical handover or a failure to transfer information, responsibility and accountability can have extremely serious consequences for patients. So again, we move away from a blame game culture at BHS. We encourage reporting, we encourage improvements, and we encourage ways that we can look at themes and implement better practices. And we've had several patient safety initiatives which have occurred as a result of actioning these reported incidents. So within the new national standards, there is a criteria around communication of critical information, but this is absolutely important for anywhere we work in BHS. So we need to identify critical information such as changes of medicines. Any new critical results always must be communicated. Any change in patient goals, so for example, the patient's goals of care have changed, we need to ensure that all our staff members are aware of that who need to be. But not also about patient information. Anything with equipment or medical supplies needs to be communicated because that can be quite critical to both staff and patient safety. And any information that requires follow-up with another clinician or the patient and their care where appropriate. So documentation of information, again, as mentioned, documentation sits with clinical handover. It is really important. There are principles that underlie good documentation, such as the acronym CLASS, so that we just must be able to communicate, that it must be legible writing, that it must be accurate, it must be specific and for safety. And another acronym that we often hear is CARE. So documentation should be compliant and complete, it should be accessible and accurate, it should be readable, and it should be enduring, so telling the next staff member what the story is and what the plan is. In relation to patient identification, probably as already mentioned, there's several governance documents around that clearly outline these processes that I've spoke about. You may want to look at any of these that are relevant to your areas. For example, if you're working in mental health, you may want to look up the ECT, Interventional Safety Checklist. Around clinical handover, there's also a number of policies and protocols around that, which clearly outline our requirements. There is some work happening in that space. also, and there should be some education coming up around that as well. Like I said, a number of clinical handover documents. Thank you.